Next, let's talk about pediatrics. So you will read throughout the course of your work that there's physiological status determines blood flow to the IV site, that neonates have absorption issues or GI factors. Basically, the younger the child, the more erratic the absorption may be. Your textbook points out, with this particular classification of young patients, that a neonate or newborn is younger than 1 month. I'd like to note that really this is 28 days. So 28 days from the date of birth. Now, if a premature or preterm infant is born, that neonatal period may be expanded. It's extended because the date is actually taken from their due date or their date of expected delivery through that 28 days. It is not quite a month. Then 1 month up to a year is considered an infant, or 28 days to a year is considered an infant. 1 to 12 years is considered a child. What you're going to find is that most of the time pediatric dosages are going to be calculated until the age of 16. Really, when we're looking at the differences, you'll notice that there are some things that will be factored in as we go through the medications and you start to learn those. So when we're looking at pharmacokinetics, the absorption is affected by many factors, including the age, again, physiological status, the stability of the condition itself, as well as the route of administration. First pass is affected because of the immature liver. And then we have gastric pH, because the gastric pH is less acidic because the cells in the stomach that produce the acid are immature. And until sometime between ages 1 and 2, that's going to be a factor in absorption. Gastric emptying is slower because in a child, peristalsis is slower. That's a normal part of being a child. Regarding IM absorption, it's usually faster and it's usually more irregular. When we look at distribution with regards to pharmacokinetics, we know that the physiochemical properties of the drug are an important consideration. Because the child is more total body water and lower fat content, those things that are water soluble or hydrophilic versus lipid soluble or lipophilic are going to be affected, as well as there is more extracellular water, and protein binding is decreased again because of the immaturity of the liver, and the pediatric patient has an immature blood-brain barrier, which means that more drugs actually enter into the brain. When we look at metabolism, the metabolism is substantially slower in adults than older children. Older children usually have an increased metabolism, which means that the dose may need to be increased. As we also noted in the pregnancy discussion, that a child can have problems due to substances that they were exposed to during when they were in utero, or that the mother was exposed to during pregnancy. Again, we have this immature liver. It doesn't produce the enzymes or the microsomal enzymes, and so metabolism is greatly affected. Now that's until 1 to 2 years of age. Genetic differences also, as we have been studying, can affect metabolism. So when we look at excretion, the renal system develops slowly and it reaches its capacity over the first year of life. So the kidneys are immature, and that kidney immaturity affects the glomerular filtration rate. We abbreviate that as GFR, the glomerular filtration rate, and the tubular secretion. So as a result of this immature GFR, or immature kidneys having a lower GFR and tubular secretion, what happens is that we have a different urinary pH. And that means that they're not able to concentrate urine. So that affects the rate of drug secretion or excretion, in the pediatric patient. When we look at pediatric patients, we know that they are more susceptible to drug overdose and drug toxicity, as well as unusual or idiosyncratic responses to drugs. And this is because of the differences in their body composition, as well as their immature organs. Some of the characteristics that render significant effects on drug dosages include that the skin is thin and more permeable, that the stomach lacks acid to kill bacteria, that the child's lungs have weaker mucus barriers. We know their body temperatures are less well regulated, and because of this, as well as their fluid ratio, dehydration occurs more rapidly and more easily. And since the liver and kidneys are immature, this impairs that metabolism and that excretion, which is very important in the neonate because the liver and kidney immaturity contributes most frequently to drug toxicity in that particular population. When we look at the potential, we look at adverse drug reaction in children, the potential for drug-to-drug interactions is increased in ill children. This is often exacerbated or even exponentially occurs because of frailty in young children. So that can add to the complexity of their illness and make things worse. Now, when we're looking at adverse drug reactions, we also have to make sure that we're considering proper dosages. And proper dosages are calculated based on weight, age, and/or surface area. When we look at these calculations for pediatric patients, they're going to be covered in more depth in LVN 111, and we'll review these again in LVN 123. But let's take a brief look at the methods used for calculating pediatric dosages. There are some acceptable methods that are used. We can use the body surface area. Now, this may be used most frequently in specialty units like a burn unit, but the more common one you're going to see in the clinical setting is likely to be milligrams per kilogram. And even some medications will require this method for specialty areas. Evidence-based practice indicates that you always weigh a pediatric patient, in kilograms, not in pounds. Do not weigh in pounds and convert, weigh in kilograms. All medical scales in use now have the ability to weigh in kilograms. And if you're working in a setting where this is not available, I would encourage you to seek out the process to find out how to get that changed so that you can help be an advocate and protect your pediatric patients, because every single time someone is forced to make a conversion, it is another potential for error. So I encourage you, always use the weight in kilograms and actually weigh them in kilograms. Don't convert it. Now, when you get to these drug calculations, you'll see this nomogram is in your book. This takes into consideration height and weight. You will also see nomograms used in emergency settings. You may see a thing called the Braslow tape, and we'll cover the Braslow tape in detail in LVN 123 when we get to pediatrics. But basically, what we're doing is we're using this chart as a way to evaluate and to come up with the dosage calculation. So I want to say a couple of things about formula. Let me back up just a second. And in dosage calculations, most facilities are going to have all calculations being done by 2 people in pediatrics, unless you're in a pediatric hospital, a specialty hospital. And then there are going to be some medications that will be double check the dosage calculation. So always, always, always check those calculations. But let's talk about the formulation. Now, many drugs for children are in the form of elixirs or suspension. They're in liquid form. Elixirs are hydroalcoholic solutions in which these drug molecules are dissolved and they're evenly distributed. They will appear like a syrup. They will be more like a syrup consistency. That's an elixir. Suspensions, on the other hand, are undissolved particles of drugs that are distributed throughout the vehicle by shaking. So if you are using an elixir, you want to make sure that the label is being read. Be sure that the patient's parents know to read the label and the dosage instructions, because elixirs are usually more concentrated. And then suspensions, if they're not shaken, there will be no medication in the first doses, and then it'll be highly concentrated in the later doses down in the bottom of the bottle. So the suspensions always need to be shaken. I will now also say a couple of things about the other routes of administration. And that should say administration. Let me just fix that right there. There we go. Crushing can increase the palatability, but remember, it is also going to affect the pharmacokinetics. Buccal and sublingual route depends on the child's ability to keep that drug in contact with the mucous membranes. They get easily distracted, and the next thing you know, they're chewing on that pill. Ophthalmic absorption is affected by a child's ability to retain that medication in the eye. It's really hard to get medications into children's eyes. Suppositories and rectal solutions are very common for neonates, but you're going to get poor absorption in older children. Aerosols are nebulizers or meter dose inhalers also depend on the child's age and ability to follow instructions. I've seen 2-year-olds able to use an inhaler, and I've seen 14-year-olds not able to use an inhaler. So maybe a nebulizer mask would be a better option. Nasal solutions are very likely to be swallowed by infants and younger children. And remember, when we swallow it, then we lose that effect and we get more of a systemic effect depending on the medication. Couple words of caution. Pediatric doses cannot be extrapolated from adult dosing information using this equivalence-based formula or means to extremes and looking at weight, milligrams per kilograms. Use medications for children that are made for children. Don't be that nurse. The other caution is that it takes literally less than a couple of seconds for a child to get a hold of a medication. I don't know how many times I have seen a child get a hold of a medication and it's in their mouth before you mean for them to have it, or it's not their medication. So always with pediatric patients, keep your eyes on those medications. You do not want to be asking yourself, did they just swallow that whatever medication I'm trying to give to them? Or if there are other children in the room, encourage you, make sure that you are not, that you're watching the medication so that the wrong child doesn't get the medication, because they want to be helpful and encourage them and show them how it's done, that sort of thing. So let's move on to our geriatric population, and we'll put that in another audio recording. Thanks so much.